Yes. Thank you for the kind introduction, and once again, thank you to the organizers of this wonderful conference. I think it's very rare that all the talks start on time and end on time for a conference, so this is one of the first few times that I've experienced that. Today, my talk is on delayed coloanal anastomosis, DCAA, after ultralow anterior resection. This is a very depressing slide. Everyone looks quite sad. And I think it's an emotion that all of us feel as surgeons from time to time as well. Especially on post-op day 5, after an ultralow anterior resection, and your resident calls you and tells you at around 1 a.m., the patient has a fever, 38.7 degrees, heart rate 110, and a bit hypotensive. Abdomen is distended, there's some guarding tenderness, and the drain is brown. And we look like this after that. And normally we ask ourselves why, and why. So anastomotic leakage after rectal cancer surgery, something, a very depressing topic for a lot of us, but all of us have experienced this before. Now, removal of more mesorectum increases the risk of anastomotic leak. And the risk of anastomotic leak increases with more distal anastomosis. So for ultra-low anterior resection, the risk is higher than a low anterior resection, right? And in the literature, the leak rate can be up to 15 to 20%. And we know that every patient like this has significant morbidity and risk of mortality. And I would say that it's dealing with anastomotic leakage from ultralow anterior resection is one of the greatest challenges we face as colorectal surgeons. Now, because of that, fecal diversion with a temporary stoma is often performed to protect against this leakage. Many people ask, is a stoma actually useful to prevent leakage? I think this paper is a very, very important one. The role of fecal diversion in low rectal cancer. It's a review of 1,700 patients from the US. 500 of them underwent coloanal anastomosis, so that's through the ACS NASScript database. And of this, 352 had a stoma and 172 had no stoma. And the no stoma group had 2 times increased risk of sepsis, double, and 6 times increased risk of septic shock, and 6 times increase of reoperation, and a significantly longer length of stay. And you can see that not having a stoma when doing a coloanal anastomosis actually is a risk factor for serious post-operative morbidity. Now, doing a stoma is not without problems, right? There's a price to protection. The stoma-related complications are quite common, like outlet issues, prolapse, retraction, skin irritation, high output, ileostomy, dehydration, and readmission. And there's also body image and psychological issues which can't really be quantified. Ongoing costs from seeing a stoma nurse, stoma appliances, creams, and the time taken to stoma reversal can be quite considerable, a couple of months, even up to half a year. So there are several data, meta-analysis showing problems that stoma related. These are several fairly recent meta-analysis. 20% of patients have a risk of stoma-related complications within 30 days. And a 6% pooled incidence of readmission from dehydration. A 4% risk of stoma outlet issues, and a 4% risk of infections. Now, what is a delayed coloanal anastomosis? It's also called a Turnbull cutate pull-through after the authors who described this procedure. And it's a technique to reduce the risk of anastomotic leakage after the surgery, after an ultralow with total mesorectal excision. The proximal bowel, instead of being joined to the anus, is pulled out via the anus. And it's left for, timing is uncertain, it's about a week or 2, before this stump is removed and a delayed hand-sewn anastomosis is performed. Now, this delay allows peri-anastomotic adhesions to form in the pelvis, and it prevents clinically significant intraperitoneal leakage. So because of the adhesions, any leak from the breakdown of the anastomosis does not travel into the abdominal cavity. And this eliminates the need for a defunctioning stoma. Now, what's the relevance? What's the similarity between David Beckham and anus? Well, some may say they're full of shit, but that's not the answer. The answer is that just like David Beckham, the Turnbull cutate procedure was first described a long time ago, but it fell out of favor for many, many decades because people say it's smelly, patients cannot tolerate it, they have incontinence. But only recently, I would say, in the past decade or so, it's returned to mainstream practice. Now, lots of data in the past couple of years. There's been one randomized trial and several meta-analyses. And all this evidence concludes that a delayed coloanal anastomosis reduces overall post-operative complications, including that of an anastomotic leak. And very importantly, oncology and function are not compromised. I will describe some of our experience at Singapore General Hospital using DCAA for emergency surgery, for elective surgery, showing its feasibility and safety, comparison with immediate anastomosis, as well as the cost effectiveness of the procedure. Now, the first case I would show is for a patient, 63-year-old. This patient underwent a low anterior resection with defunctioning ileostomy, with anastomosis quite low after the initial surgery, 4 cm from the anal verge. And this anastomosis was intact on contrast scan, and the ileostomy was reversed 3 months later. However, 6 months after ileostomy reversal, the patient came back again for anastomotic leak with a pre-sacral collection. Here you see the scan. And on the scope, this defect is very small. It's just a pinpoint defect. We tried CT-guided drainage, which failed. The leakage recurred. Don't know why it's playing by itself. The collection recurred, and endoscopic therapy also failed. The patient had progressive sepsis. The patient underwent laparotomy and hydrolysis, open mobilization and transection of the proximal bowel, and a TATME was performed to mobilize and excise the old anastomosis. And this time the patient did not want to do an stoma. So here you see the defect of the excision of the old anastomosis, and that's the Turnbull cutate pull-through. So we did not join, we pulled out the proximal bowel. Time was about 5 hours surgery with blood loss of 250 mils, and the pelvic drain was purulent, but it was clear with minimal output by post-op day 5. And a scan showed there was no collection on post-op day 7. So the time having the delayed anastomosis allowed the sepsis to settle down. So you see that's the pull-through on day 8, and after amputation, that's the appearance of the coloanal anastomosis. So this delay actually allowed the sepsis in the pelvis settle down before we do the final anastomosis. So you can see the timeline here. On day 11, the patient was discharged, and we described this in a video vignette, and you can watch this on YouTube for the full procedure. Now we also do elective DCA for low rectal cancer. In this patient, 68-year-old male, BMI 21, with low rectal adenocarcinoma, there were no metastasis. This tumor was 4 cm from the anal verge and 1 cm from the anal rectal junction. Here you can see the tumor on endoscopy as well as the MRI scan. These are the ports we use for the surgery, laparoscopic ultralow anterior resection. We also did TATME for this patient and performed a delayed coloanal anastomosis without bowel diversion. So we did the usual splenic flexion mobilization, IMA high tie, and a left-sided bowel mobilization using these ports. And here we see the part where the flexure is fully taken down and the left colon is fully mobilized. That's the fully mobilized descending and sigmoid colon. And we take the dissection down to the pelvis, the rectum. This is the usual thing that we've seen over the past few days. So for patients with DCA, oftentimes I do a TATME as well because these two procedures are synergistic. That's the fully mobilized rectum up to the mid-rectum. And here I transect the proximal mesentery. And this is performed up to the bowel wall. So I don't transect the bowel now. Instead, I occlude it with a tie. This is so when I do the TATME, the proximal bowel does not distend with gas. And also when I do the pull-through, the bowel is already oriented correctly. I don't have to, get someone to make sure the orientation is correct and pull it out at the same time. I can just pull it out after doing the dissection from below. So you must test to make sure there's enough length, even though the flexure is taken down. And after that, we do a TATME from below. This is using the gel point path. And you see the tumor is really low. It's just sitting right above the inner flange of the channel. And we do a transanal purse string suture to occlude the lumen just distal to the tumor. And this is tied externally. It's a Prolene 2.0 purse string suture. And a very important step now is to clean and wash the distal lumen so that when you do the rectotomy, there's no pelvic soilage from remnant intraluminal content. I do a 2-layer purse string just in case one layer doesn't hold. I think it's a very important step when doing a TATME. And then I start the TATME, and that's the circumferential rectotomy. And I rendezvous with the laparoscopic TME plane. Now, because we've done the laparoscopic TME plane quite low, it's quite quick to rendezvous. You can see that barely 10 minutes later, I've rendezvoused with the laparoscopic dissection plane. So it's just to secure the distal margin. And why I say that this procedure is synergistic, DCA is synergistic with TATME, is because there's already an open rectum after we do a TATME, right? There's no staple. So you can just extract the specimen, perform a natural orifice extraction, as well as do a delayed coloanal anastomosis. So here you see it's already oriented because I did not transect the proximal bowel. That's the IMA stump there and the proximal bowel, and I transect the proximal bowel with the scissors just distal to the purse string suture. And this pull-through stump is anchored to the top of the anus using anchoring Vicryl trio sutures. And this is a bit too long. If you leave it so long, the patient, the stump will get ischemic. You cut it back to about 5 centimeters, and that's the specimen. You can see that this, even though you have direct visualization, is still a very, very short distal margin, but adequate oncologically. And this is the final abdominal appearance without a stoma, I must add. So this is the stump appearance on post-op day 1. As I said, I cut it back, but even then, only being 5 centimeters or more outside the body, it still swells because of the sphincter. You get a bit of impaired venous return. So it's edematous, but importantly, it's not ischemic, right? It's just edematous. You can see after 6-7 days, the pull-through looks a little bit more ischemic now, but the mucosa is still healthy. And you can see that the short segment that is external to the anus is still healthy as well. After amputation of the stump, we do a hand-sewn coloanal as usual, and you can see that the appearance looks quite normal, as how you would do an immediate coloanal anastomosis. Now, this patient had a T3 N1B adenocarcinoma. The distal margin was 5 mm, and the TME plane was complete. This patient was followed up for 15 weeks. There was no post-operative complications. The patient had adjuvant chemotherapy because of the N1 disease. And you can see that the function is not that bad. After 15 weeks, there's only minor loss and a Rexon score of 20, and this continued to improve. And of course, the patient was very happy not to have a stoma. Now, this is one of our early experiences. We described it in the techniques of pathology, and we realized that a TATME and a delayed coloanal anastomosis for a low rectal cancer are complementary techniques, and they provide good perioperative outcomes. But what are the concerns here with a DCA? Number one, you have an increased length of stay because instead of going home on day 4 or day 5, you have to wait 1 week or 5 days now, followed by a second procedure, and then you go home after that. So increased length of stay. And then the next question is it cost effective? Additionally, the other question is both TATME and DCAA result in the sphincter stretching individually. So added together, is there a combined effect or aggravated effect on anal function and LARS? Now, we did sort of like a theoretical analysis of the two pathways ICA and DCA, and we used the stats from existing papers or the risks from existing papers to input onto this theoretical pathway decision tree model, including the RCT published in JAMA Surgery. And we found that DCA is an overall cheaper strategy compared to ICA at a cost of £1,000 less. And why? This is because of the decreased overall costs of the two length of stays. The first one, ICA, is the index surgery, followed by the return for stoma reversal, whereas there's only one length of stay with two different surgeries in that length of stay for the delayed anastomosis, as well as the reduction in costs associated with anastomotic leakage or stoma-related complications, specifically dehydration-induced readmissions and avoidance of the stoma maintenance costs. Now, of course, this is all theoretical, right? We want to see real-world data. So even though we said, okay, maybe more cost-effective, but we want to do our own data to assess this question. So we compared TATME, DCA, versus laparoscopic TME with ICA and robotic TME with ICA, and perform a propensity match analysis of short-term outcomes, function, and costs. And this is done at my hospital, and it's from patients who perform from surgery from November 2021 to June 2022. And we include ultralow anterior resections for low rectal adenocarcinoma with sphincter preservation and coloanal anastomosis. So propensity match them in a ratio of 1:3:3 by age, gender, BMI, ASA score, and the use of new-adjuvant RT. Now, we only use the DCA procedure with transanal TME, no laparoscopic or robotic TME. And all procedures were hand-sewn for DCA, and all ICA procedures were stapled. And all ICA procedures at our unit are routinely defunctioned with ileostomy. So here you can see the characteristics of the patients. Now, very importantly, all patients were matched in terms of preoperative chemoradiation, and the distance of the tumor from the anal verge was not different. It was 5 centimeters median. And here you can see there was no difference in terms of distal margin, even though the robotic had the longest distal margin of 1.5 cm. And I suspect this is because when you do a TATME, you don't take more than necessary, right? You only take what you can see, and 1 cm is adequate enough. And all margins were clear for the TATME, and not different from the laparoscopic and robotic TME. Sorry. So here you can see the characteristics between the TATME, laparoscopic TME, robotic TME for T stage, N stage, and lymph node harvest are the same. And these are the outcomes. So this is the interesting bit. The index surgery operation is much faster with TATME because there's no stoma creation, of course. And all this is done by one team, so not a sessile approach, no two-man team for TATME. And the length of stay, of course, longer for TATME and DCA is 10 days. And this is early on in experience, but nowadays it's been cut to a median of 7 days. But regardless of that, initially the comparison was much longer for TATME. And the median time for delay from the TATME to DCA is 7 days. And the median time of reversal for the defunction group in laparoscopic and robotic TME was 4 months. So that's quite some time. And after including the length of stay of the second admission of the defunction group, actually there's no difference in terms of length of stay. It's about 9 to 10 days for each group. So complications-wise, there was 11% complication rate for both laparoscopic and robotic group, and there was no stoma-related complications at all because there was no stoma created for the TATME DCA group. So this is a very important point. And you can see that there was no difference in terms of function in LAR score on follow-up. So here we have the breakdown of complications. There was no major complications for the TATME group. And cost-wise, if you look at the costs of the index hospitalization, the highest is the TATME DCA group. But when you factor in the cost of the stoma reversal admission, actually the cost of TATME DCA is quite similar to the cost of laparoscopic TME and ICA, and robotic has the highest cost overall. So in conclusion, it is cost effective. And don't forget that this only took into account the hospitalization stays. It doesn't take into account the cost of outpatient, of stoma appliance, stoma nurse visits, etc., psychological cost having a scar, a wound, and it does not include the cost of readmission for complications in the defunction group. This is a different way of showing the same data. You can see that overall cost, robotic is the highest, followed by TATME, but just slightly higher than laparoscopic TME with ICA. Now, lastly, cosmesis is not to be overestimated or underestimated, sorry. Here you can see a robotic TME with ICA without natural orifice extraction. You can see the mini midline extraction site. And this is the difference, having a TATME, DCA, and having no stoma. So the benefits, firstly, is no stoma. Reduce ports because you do a TATME, you can augment the laparoscopic TME incision, and you don't need so many ports to do the same surgery. You can do natural orifice surgery, and there's no drain because there's less risk of leak, so I don't routinely put a drain, even for ultra-low resection. In conclusion, delayed coloanal anastomosis is safe and feasible. It is done best with TATME. It has similar short-term outcomes, histo results, mobility rates, and bowel function compared to other MIS approaches of TME. Very importantly, it avoids the stoma and stoma complications, and it may be useful for salvage surgery or post-radiation in particular. And overall costs of TATME DCA are comparable to laparoscopic TME ICA and significantly cheaper than robotic TME with ICA. Thank you very much.
Thank you for the excellent talk. I have some question for you. And how can you select the Turnbull case?
So many people, they do it for salvage. So if you have a ultra-low anastomosis leak, you have a chronic sinus, you have a stricture, you can do Turnbull cutate. But for me, I do it for all patients which I think will benefit from a coloanal anastomosis. So even elective low rectal cancer that is about 5 centimeters or less from the anal verge. I do it for all patients.
Thank you. And another question, how you take care of your conduit and what the level that you're gonna cut after the granulation has already grown?
Yes, so we use a D50, dextrose 50% soaked gauze to cover the conduit, and the nurses in the ward changes it twice a day. So it keeps the stump moist and it draws water out the stump so the edema is not so bad. That's what I do. How you cut about 1 cm distal to the top of the anus. Not too short, not too much. Because if you leave too much, that is safer, but you have a lot of tenesmus because there's bunching of the mucosa and the tissue, and patient can have more worsened LARS. So if you cut just 1 cm or slightly less than 1 cm, maybe 7 to 8 millimeters, that's the best level to transact the stump for hands-on coloanal anastomosis.
Thank you so much.
Thank you. Oh.
There is one question from the floor.
During demarcation, the patient eat or nothing per oral?
Yes, so the time, you're saying the time between the surgery and the delayed anastomosis?
Delay.
Yes.
Waiting for the demarcation for cut the conduit, and that time you
Yes.
let the patient normal
Yes.
eating or NPO?
Yes, good question. So initially, I put the patient on TPN because if the patient eats, they are invariably incontinent because the sphincter is stretched and they have no ability to control anything. So if they eat, it's okay, but the nurses will kill me in the ward because they saw the bed. So I give them TPN to prevent a catabolic state. But now, in the recent 6 months, PPN is now available at my hospital. So I give them peripheral nutrition for the 5 to 6 days before the surgery is done. And that prevents the solage of the bed. But some patients, they insist to eat, I let them eat. I just tell the nurses to prepare to deal with the incontinence.
Thank you.
Thank you for excellent presentation. Would like to ask, in the worst scenario that the prolapse segment is turned gangrene, how to use salvage, because we don't know if the necrosis is extend into the
Yes.
into the pelvic. Second question is, you also send the resected the bowel for examination and include the number of lymph node in the pathologic result?
Yes. So the first question is a very important one. Of course, we try to prevent that from happening in the first place by ensuring that when you transect the bowel outside, the marginal is spurting. If it's not spurting, I pull out more. Yeah, so it must be spurting. So if it's just a dribble or there's a bit, it means that the marginal artery may be kinked or maybe not so good. I pull more and then cut back until it's spurting at the first surgery. So one case after a sort of exenteration, where I did a pull through and the stump looked very unhealthy. So I put a test tube in the anus, look at the mucosa. That was fine. Yeah, so if the external part looks a bit gangrene, maybe because of patient is sitting down or there's some twisting in the marginal, maybe the tip can look a bit unhealthy. As long as the level that you want to intend to anastomose is healthy, then I just leave it. Yeah, I can leave it. The same question is about the histopathology. I send it for histo, yes, the stump, but I don't include the lymph nodes into the initial report.